Welcome, everyone, and I'm glad you could attend to our Population Data Science webinar series for today. My name is Anne Greenwood. I'm the Education and Training Lead for Population Data BC. And today it's my pleasure to introduce a panel of presenters who will be speaking on lessons learned. It takes a village to understand intersectoral care using administrative databases across jurisdictions. We have a number of team members on the line today who will be presenting. But first, I'd like to introduce Bojana Petrovic. She's a research associate and part of the team that's presenting today. Bojana will be managing the slide deck for the presenters. So thank you very much for doing that. Other presenters today are Dr. Patty Groom, Mary McBride, Dr. Kathleen Decker, and Cynthia Kendall. By way of introduction, Dr. Patty Groom is an epidemiologist and senior scientist in the Division of Cancer Care and Epidemiology at Queen's Cancer Research Institute and a professor in the Department of Public Health Services at Queen's University in Kingston. Her research involves the delivery of health services to persons with cancer, most recently with a focus on the problem of late cancer diagnosis. Dr. Groom co-chairs the administrative data subgroup of the Canadian team to improve community-based cancer care along the Continuum. Mary McBride is a recently retired epidemiologist, health services researcher, and distinguished research scientist in cancer control research at British Columbia Cancer Research Centre, and a clinical professor in the School of Population and Public Health, University of British Columbia. She is an expert on record linkage methodology and uses linked population-based registry clinical and administrative databases to examine epidemiologic, clinical, and health system perspectives on cancer outcomes and cancer care. Dr. Kathleen Decker is a scientist in the Research Institute of Oncology and Hematology and the senior epidemiologist in the Department of Epidemiology at Cancer Care, Manitoba. Kathleen is also an assistant professor in the Department of Community Health Services, Max Rady College of Medicine, Rady Faculty of Health Services at the University of Manitoba in Winnipeg. Cynthia Kendall is a project coordinator and research associate with Cancer Outcomes Research Program at Nova Scotia Health Authority in Halifax. Her research areas include cancer health services, knowledge translation, frailty, and advanced care planning. So welcome to the team this morning, and thank you for all the logistical work that went into bringing your team together to present today. So without further ado, I'd like to pass the presentation over to our first presenter, Mary McBride.
Thank you, Anne. I'm going to start the presentation today of our CanIMPACT study by outlining the scope and the framework of the project. Bojana, next slide, please. First, our support has come from the Canadian Institutes of Health Research and the University of Toronto. Next, our presenter disclosure statement indicating we have no relationships with commercial interests. Next. So this research addressed understudied issues related to the fact that primary care has critical roles to play in providing care for cancer patients in all phases of the cancer continuum. Our goal was to support the enhancement of the capacity of primary care to provide care to cancer patients and improve integration between the primary care and cancer specialist roles along the cancer journey. Next, this continuum involves the trajectory from prevention to survivorship or end-of-life care. CanIMPACT explored the screening, diagnosis, treatment, and survivorship phases of this journey, plus personalized medicine, that is, care that is customized for the individual patient based on predicted individual responses or risks of outcomes. Next, the framework of the research included a phase 1 with analysis of administrative health databases, interviews of survivors and physicians, focus groups, an environmental scan and systemic review of initiatives to improve care integration and development of synthesis maps, as well as a phase 2 that developed and trialed a chosen intervention. Next, the segment we're presenting today is about analysis of administrative health databases. Next, this work involved using linked provincial administrative health data sets to inform the development of our potential interventions to improve care. Specifically, we assessed and compared care for breast cancer patients across the care continuum in 5 Canadian provinces, overall and among specific subgroups, and examined the interplay between primary and oncology care of these patients, exploiting previous work by the investigator team in their respective provinces. Next, the study populations consisted of all women in each province diagnosed with a new invasive breast cancer between 2007 and 2011, or latest year available, and followed to the end of 2013, or latest year available, in each of the 5 provinces of British Columbia, Alberta for diagnosis phase only, Manitoba, Ontario, and Nova Scotia. Next, the specific cohorts, just give that a minute, consisted of the total group for the diagnosis phase, those who had stage 1 to 3 breast cancer at time of diagnosis and who also had surgery for the treatment phase, and patients who had surgery and were alive at least 1 year post-diagnosis for the survivorship analysis. The cohort sizes are at the bottom of this slide. Not surprisingly, Ontario had the largest study group and Nova Scotia had the smallest. Next. We examined several outcomes in each phase, specifically the percent screen detected in the diagnosis phase and the interval between either screen detection or first symptomatic physician visit to confirm diagnosis for those who were diagnosed symptomatically. For the treatment phase, we looked at the extent of use of chemotherapy, as well as the extent and patterns of serious toxicity through late effects and resultant primary care physician visits. For the survivorship phase, for years 1 to 5 post-treatment, we examined follow-up cancer care guideline adherence, primary care and oncology physician patterns over time. Also, continuity of care, both at baseline, sorry, and this is backing up a bit, continuity of care, both at baseline and at the start of survivorship. PCP visit levels, both pre-diagnosis and at the start of survivorship, and quality of chronic illness and preventive care, both at baseline, pre-diagnosis, and survivorship. Next. Oh, sorry, can you go back one, Boyana? I should mention we also examined the potential effect of regional variation, both inter and intra-province, and vulnerability related to older age at diagnosis, lower income, non-Canadian status, rural or remote residence, and high levels of comorbidity. Thanks. Next. The data sources involved included our provincial cancer registries, health insurance plan client registries, census data, physician billing, breast screening data sets, the inpatient hospitalizations or the DAD, and as well treatment data, and for BC and Ontario only, the Canadian Refugee and Immigrant Database. Now for the key findings. Next.
So let's move on to the next slide. And I'm going to just give some summary results for each phase of care, starting with the diagnostic phase. So this first figure shows the percentage of cancers detected by screening by age group for BC, Alberta, Manitoba, Ontario, and Nova Scotia. 5 age groups were examined: 40 to 49, 50 to 59, 60 to 69, 70 to 74, and 75 years of age and older. In Alberta, Manitoba, Ontario, and Nova Scotia, the percentage of breast cancers detected by screening was highest for women 60 to 69 years of age, while the percentage was highest for women 70 to 74 years of age in BC. The percentage of screen-detected cancers were very low in Manitoba for women younger than 50 or older than 74 because the organized screening program does not target women in these age groups. On the next slide, the table shows the median diagnostic interval for BC, Alberta, Manitoba, Ontario, and Nova Scotia for women who were diagnosed with breast cancer through screening, and for women diagnosed with breast cancer through a non-screening diagnostic pathway, most likely because they were not asymptomatic. A range is provided because the median diagnostic interval was calculated for each health region within the province. The median number of days varied both across and within provinces. For women who had a screen-led breast cancer diagnosis, the median varied by as much as 34 days in Alberta, and for women who had a diagnostic-led breast cancer diagnosis, the median varied by as much as 26 days in Manitoba. Although it's not included in the table, we found that older age was not associated with longer diagnostic intervals in either the screen-led or diagnostic-led groups, but increasing comorbidity was associated with longer intervals in the diagnostic-led group. In addition, we also found low-income and rural residents were associated with a longer median diagnostic interval in BC and Ontario for women in the screen-led group, and in Nova Scotia for women in both the screen-led and diagnostic-led groups. We were able to look at the median diagnostic interval for immigrant populations in Ontario and BC and found that immigrants typically had longer diagnostic intervals compared to long-term patients. The next slide illustrates the percentage of women in each province who had surgery divided into lumpectomy or mastectomy, chemotherapy, divided into adjuvant, neoadjuvant, or otherwise not specified, and radiation therapy. So the blue bar is BC, the orange bar is Manitoba, the gray bar is Ontario, and the yellow bar is Nova Scotia. The percentage of women who had a lumpectomy was similar between the provinces, but mastectomy was more common in Nova Scotia. And this is likely related to the need to travel for radiation therapy, so that women may choose to have a mastectomy rather than a lumpectomy, followed by traveling to Halifax for radiation. We also found that adjuvant chemotherapy was higher in Manitoba and Ontario than BC and Nova Scotia. In additional analyses, we found that the receipt of adjuvant chemotherapy was less likely for women over 70 years of age and for those with increasing comorbidities in all provinces, and was also less likely for women with lower incomes in all provinces except Nova Scotia. In addition, rural residence was associated with lower levels of adjuvant chemotherapy in Nova Scotia. And then lastly, the percentage of women who had radiation therapy was lower in Manitoba and Nova Scotia. The next slide shows results about the impact of chemotherapy on clinical outcomes and healthcare use. So figure A shows the percentage of women diagnosed with stage 1 to 3 breast cancer who had curative surgery and at least one emergency department visit, which we've abbreviated as ED, hospitalization versus the emergency department, abbreviated as EDH, or direct hospitalization, abbreviated as H, for any reason for each province. BC is the blue bar, Manitoba is orange, Ontario is gray, and Nova Scotia is the yellow bar. Ontario had the highest percentage of women visiting an emergency department, but the lowest percentage with a direct hospitalization. Conversely, BC had the lowest percentage of women visiting an emergency department, but the highest percentage with a hospitalization. Figure B shows visits and hospitalizations for cancer or chemotherapy-related reasons. And the pattern is similar for emergency department visits and hospitalizations via the emergency department. And direct hospitalizations were higher in BC compared to the other provinces. The final figure, figure C, shows the percentage of women who had an emergency department or hospitalization for issues related to febrile neutropenia. Emergency departments were slightly higher for Manitoba, while hospitalizations via the emergency department were lower. We also found that different factors were associated with emergency department visits or hospitalizations. So in all provinces, comorbidities and geographic location were associated with emergency department visits, and age and deprivation index were associated with emergency department visits in all provinces except BC. Income quintile was associated with hospitalization versus the emergency department in Ontario and Nova Scotia. Comorbidities and geographic location were associated with hospitalization versus the emergency department in all provinces, except Nova Scotia. And lastly, age and geographic location were associated with direct hospitalization in all provinces, while deprivation index was associated with hospitalization in Ontario and Nova Scotia, and comorbidities and rurality were associated with direct hospitalizations in Manitoba. The next slide shows adherence for physician visits, breast imaging for surveillance, and breast imaging for metastatic disease during the survivorship phases of care. So adherence for physician visits was defined as 3 to 4 visits in the 2nd and 3rd years of follow-up and 2 visits in the 4th and 5th years of follow-up. Adherence for physician visits was high for all provinces, and greater than 80% of women diagnosed with breast cancer in our cohort had at least 1 physician visit. The top figure illustrates adherence for breast surveillance imaging. So adherence for surveillance was defined as 1 mammogram, breast MRI, or breast ultrasound per year. The y-axis shows the percentage of women, and the x-axis shows the year of follow-up. The blue section represents surveillance breast imaging that is less than recommended. The green section represents surveillance breast imaging that is consistent with recommendations. And the pink section represents breast surveillance imaging that is greater than recommended. And results were available for BC, Manitoba, Nova Scotia, and Ontario. Underuse, the blue area, is common in all provinces, but most pronounced in British Columbia. And overuse, the pink area in Nova Scotia, is likely related to how the data was coded. So in all provinces except Nova Scotia, mammograms, ultrasounds, and MRIs were classified as surveillance tests if they occurred more than 330 days from the date of the test, the last test, implying that they were not related to symptoms. However, in Nova Scotia, these tests were identified as surveillance tests. Now, the bottom figure illustrates adherence for imaging for metastatic disease. Adherence for imaging for metastatic disease was defined as no imaging. The turquoise section represents adherence or no imaging, and the pink section represents non-adherence or some imaging. As you can see, overuse was common, and the effective age, comorbidity, residence, income, deprivation varied by the type of imaging test, but overall, no general trends were evident. The next slide shows variation in primary care provider visits for the diagnostic treatment and first survival year compared to pre-diagnosis levels for BC, Manitoba, Ontario, and Nova Scotia. So primary care provider use was higher during diagnosis compared to pre-diagnosis in BC, Manitoba, and Ontario, but lower in Nova Scotia. And this may be related to the use of navigators in Nova Scotia who track and proactively facilitate further investigation for all women with imaging findings that require further testing, whether or not the women were screen detected or detected through a diagnostic mammogram. Primary care provider use was higher during treatment compared to pre-diagnosis in all provinces. However, this was most pronounced in BC, where primary care use was over 6 times higher during treatment. So clearly we found that primary care providers are involved in the care of women diagnosed with breast cancer throughout treatment. In summary, on the next slide, the CanIMPACT studies using administrative health data found variations in the diagnosis, treatment, and follow-up of women, a follow-up provided to women diagnosed with breast cancer across the provinces. And these observed variations in care indicate potential practice and system-level opportunities for care improvement towards Canada's Health Act requirement for comparable, effective, equitable, and accessible care. Dr. Patty Groom from the Department of Public Health Sciences at Queen's University will now talk about lessons learned from the CanIMPACT project.
Thank you, Kathleen, and welcome everybody. So I'm going to tell you about our lessons learned from a methodological point of view to provide some information for those of you who may be interested in doing cross-jurisdictional work similarly to what we've done. Next slide. So the objective is to provide you with some guidance for future cross-jurisdictional research based on the lessons that we've learned. I will direct your attention to the citation at the bottom of this slide if you want more information about this. Next slide. So in order to do the analyses that you just saw Kathleen summarize, we had to create parallel provincial level data sets, and instead of combining all of the data into one data set and analyzing in one site, and that was due to feasibility issues as well as privacy and permission issues in the different provinces. So it was quite a challenge for us to create parallel data sets that were equivalent, and in order to do that we had to take a number of steps to ensure that that was going to occur. So some of the key issues that we found were important were to make sure that we include investigators on the team who have prior knowledge about the data available in their provinces, along with prior, at least province-based experience in using those data. We had, as Mary mentioned briefly earlier, we had at least one investigator who had research experience pertaining to each of our objectives on the study team. Communication, as you can imagine, was crucial in order to create these similar data sets, and we had bi-weekly conference calls in order to make sure that we were all on the same page. This also gave us momentum with regard to getting the work done. Another key element to what we did was to use common data set creation plans. So these plans are like recipes for how to conduct the study. We developed those plans centrally with everyone agreeing on what we were going to do, and then they were modified for each province. So this was a communication tool to make sure that we were comparing like with like when we compared the data. Next slide. So I'm going to spend most of the rest of my time on this slide to walk you through our recommendations for conducting interjurisdictional administrative data studies. The dark blue boxes are what we're recommending the project infrastructure should look like should you decide to get involved in or conduct one of these studies. And the light blue graph or cycle here describes the project processes that we would recommend. So starting at the top, the study team expertise should include clinical expertise, expertise on how the local healthcare system is structured, expertise in study design and analysis, understanding of the vagaries of the local health data, so experience with using those data for research, and very importantly, project coordination and management, central coordination and management throughout the period to provide consistency and to make sure that that there is a memory on what has been done and to move forward. The star here is to remind me and you that having at least 2 core members from each jurisdiction is a really good idea to ensure that you've got a quorum on your bi-weekly calls. Moving to the left-hand side of the slide to look at the other infrastructure we would recommend, having a centrally controlled document archive is very important, making sure that that's easily accessible and that it contains the newest version of the files with other previous versions archived. So this would be, for instance, one role that the project coordinator would take on. This archive should include not only, for instance, the most recent version of the dataset creation plan that everyone has agreed to, but also all of the project documents having to do with data sources, having to do with meeting minutes, etc., so that we have an archive to make sure that we keep track of what's been done. The second box here is related to the data set creation plans. These, if you're not familiar with such a thing, these are essentially a recipe for how to conduct the study that is given to the data programmer analyst so that they can process the administrative data. These are living documents that get modified as the project moves forward, and they include information about what data sources to use, how the study population or cohort is defined, including things like inclusion and exclusion criteria, details on how the variables are defined, so you can imagine how that is important, and what data sources are used to create those variables. Also, they're used, or should be used, or we think should be used, to document what we learn along the way about data idiosyncrasies, how the data might be different in one place versus another. So, for instance, you heard Kathleen talk about the difference in how the follow-up, the survivorship data was collected for surveillance imaging in Nova Scotia, and we had to take that into account when we interpreted the differences we were seeing. This is moving to the next box, standardized resources. We shouldn't be creating new methods, we don't think, in conducting these kinds of cross-jurisdictional studies. We should use existing methods and standard resources to the extent that that's possible. In other words, be conservative on the methodology because it's challenging enough to create data sets and analyses that are similar. So use common data sources whenever that's possible, standard variable definitions, and even standard data programming processing processes. So things like sharing SAS code to make sure that the way variables are defined is common across jurisdictions. And lastly, we compiled our results as we were going along. As soon as we started creating results, we put them into common spreadsheets with columns representing each province so that we could very quickly see when there were differences in practices and make sure that those differences were real. So if we saw a big difference, for instance, in the use of primary care docs in the diagnosis phase in one province early on, we went in and double-checked the coding to make sure that, in fact, we were doing the same thing across provinces to make sure that those differences were real. So that's the infrastructure that we would recommend to do this kind of work. And then moving to how the project actually gets conducted, this looking at the light blue boxes here, this first cycle on the left-hand side would be what you would do to develop the project proposal and refine the project plan before you start diving into the data. So the need for a conceptual framework so everybody's on the same page about what is it that we're trying to achieve, what questions are we asking, what variables are we interested in collecting. From that framework will arise the provisional objectives for the study and a variable list of what we're trying to collect, and then going through an initial data assessment using the expertise from the study team to talk about, do we think the data are going to be available to create all of the variables we're interested in? Do we think that the study cohort is going to be large enough to answer the questions that we're interested in? Are the data going to be comparable, or are we going to have to make compromises on which data source to use in one place versus another? Or are there differences in data collection processes that could create non-comparability? And then what do we know about data completeness? So making sure that we've got a feasible plan moving forward, let's say at the proposal stage and at the early stages of the conduct of the study, and then moving forward in the rest of this pathway to revising our objectives, our framework, and our variable list based on that knowledge, and then come up with provisional manuscript and knowledge transfer translation plans so that we keep focused. So you would have very early on a list of manuscripts you want to produce from this work. That would then feed into revising your variable list and analysis plans. And it's at that point that you would start looking at the actual data to see whether the data completeness and validity is what you thought it was going to be. Again, that gives you a chance to refine your plans, cycle around again until finally you have your final manuscript plans, KT plans, and analysis plans to disseminate as we've been doing today. So the next 3 slides, Boyan, if you just want to zoom through, reiterate some of what I just said. We've included them here for future use on this webinar in case people want to take a closer look. And then finally, just to report out on our knowledge translation, next slide, activities. So far, we've made 21 presentations at joint conferences with policymakers and clinical researchers. We've done a further 21 presentations and 5 publications to clinical research audiences about our work. We've got 2 methods-focused presentations and the methods publication that I referenced at the beginning of my section of our talk. We've presented to local policymakers and program managers at the provincial level to inform them about what we're finding to help them manage the system. We've also made presentations to local clinical groups and to the general public through 1 publication and through our website, which is noted here. Next slide. This is a slide of the disclaimers from about the healthcare custodians, and that this was our work and not work of the health data custodians. And finally, next slide. We'd like to thank you for your attention. If you'd like more information about our work and to see our list of publications, for instance, and to learn about the intervention moving forward and the other groups that had done work related to the CanIMPACT goals, we'd welcome you to look at our website. And if you have any further questions after this webinar, I'd be glad to answer them via email, or so would Boyana. Thank you.
Thanks very much, Patty and team, for your great presentation. Really appreciate all the information you provided our listeners and audience today. The chat function is now open. I've noted a couple of comments that have come in already. Just people looking for the research papers that were part of the International Journal of Population Data Science. And Boyana has kindly reminded everyone that they can find the publications on the website at CanIMPACT.toronto.ca. You'll see that in the chat function as well. But if you have any questions or comments just for any of the presenters today, please feel free to use the chat function now to send in your questions. I know there's quite a number of people on the line. Question, can you remind us about why Alberta is missing in most of the results? I don't know who would like to take up that question.
I could take that if you like. It's Patty.
Okay, thanks, Patty.
Okay. Alberta had done some work on the diagnostic phase coming into the launch of the CanIMPACT project. The investigator that we had in Alberta unfortunately moved to the United States, so we could not continue past the diagnosis phase to do the work in Alberta.
Great, thank you. Another question. Thanks for your presentation. I'm curious to know the timelines you had to achieve this work. Any takers on that question?
Mary, you're giggling. Do you want to answer?
That's an excellent question, and it's true that this work did take a fair amount of time, but that time varied by stage and by province. The first phase after funding was getting approvals REB and data steward approvals, and getting the data sets. And that varied considerably from, and please provincial reps correct me, from a few months to well over a year. A second important phase was the phase you described, Patty, in getting to the point where we had data creation plans that we felt we could move forward with. And that took almost 2 years, I would say, partly in the same period as the data approval process. But the two were linked in that we did have to provide, of course, specific requests for identified data items and fields and files. And so the evolution of our applications for data was in parallel with the evolution of our data creation plans to a certain extent. The analyses took well over a year, in particular because of the cycling that Patty mentioned as we delved into the data sets and identified discrepancies, differences in the feasibility in defining specific data items or variables. So overall, the final analyses were produced only, I'd say, in the last 6 months of 2+ years of analysis.
Okay, thank you very much, Mary. Long and a very involved process, so a lot of commitment to keep it going. Another question, how did you ascertain the immigrant status? What database data set was used? I recall mention of immigrant status predictive of some outcomes.
So for immigrant status, we've published one paper using the Citizenship and Immigration Canada data for BC and Ontario. So that's the variable that provides us with information about not only when a person came to Canada, but what their region of origin was. So I would direct you to Aisha Lofters, is the first author on that, her paper. We also did track whether or not, if I'm remembering correctly, whether or not a person had insurance status for less than 10 years. And we took that group to be newcomers to the province and looked at that across all provinces as a rough estimation of immigration status as well. But we did a very detailed look in Aisha Lofters' paper for BC and Ontario.
Excuse me, Patty, it's Mary. Can I add that we also used a neighborhood-based measure of tertiles of the percent immigrants in small regions, which was just another way of exploiting the data that we had available across provinces.
Thank you, Mary. I'd forgotten that.
So just a clarification of Jessica's question. I wasn't sure what to make about the slide which showed BC had higher direct admissions, but wasn't sure what this means in terms of appropriateness of resource use or optimal use.
Patty, can I start? Because there's sure. a couple of interpretation issues, and thank you, Jessica, for asking the question. One reason for the result you see is data availability, in that BC does not have a database that directly records all emergency department visits. So our only source was the billing, the DAD, sorry. So we believe that we actually are underreporting the number of emergency visits. in our results. I think the second part of your question is, is there a preferred or an expected distribution of those types of visits? And I'm maybe not the best person to answer that question. Certainly, there's a cost difference, but there may be a reason why some individuals would be expected to come in through emergency, just depending on the type of toxicity they're experiencing, versus and not be admitted, versus those that would require hospitalization for treatment.
And it's just to add a little bit to what Mary is saying, it's a very good question, because as you were speaking, I'm thinking we really should have also combined all of those, because the whole issue with tracking use of hospital and use of emergency is, while someone is undergoing chemotherapy, it's an indicator of stress. It's like a measure of adverse events, if you will, with regard to the delivery of chemotherapy. So a woman undergoing chemotherapy for breast cancer, having to go to the hospital in any configuration is not a good thing.
And Patty, can I just add one more thing? The data is there to actually identify for which health conditions, which adverse effects the admission is taking place. And if there was additional funding, one could drill down and look at those types of reasons for admission. And that would probably provide even more insight as to what would be an appropriate reason for emergency admission versus hospitalization. And that would actually, I think, contribute more to the development of specific, perhaps, strategies for improved care.
Okay, thank you very much. Another question from Amy. Do you have any advice on how you dealt with privacy legislation that differs across jurisdictions and obtaining variables? Do you have a central repository for storing and pooling the data, or did each jurisdiction analyze separately?
I'll take that. Each jurisdiction analyzed separately. All of the data were kept in each province and did not travel. The processes for privacy, for accessing the data and thereby ensuring privacy, differed across the provinces by quite a bit. And also the infrastructure for doing this work differed across provinces. So that was a big challenge with this work, was dealing with the different requirements in the different provinces, and another reason why it was so important to have people with experience in each province using these data on the team.
Great, thank you very much for that clarification. Any further questions? I'm just checking the chat function, additional questions people have. Any additional comments from the team? Again, thank you so much for presenting today, and as a team working across Canada, not only to present at this webinar, but clearly to do the work that you did over a number of years was an outstanding feat, I'm sure, to work through all of that. So thank you again for sharing your experiences and all that you've learned along the way. Any final thoughts in terms of best practices or things that you'd like to recommend before we close?
I would just direct people to, if they're interested in knowing more about the challenges that we faced, the paper in the International Journal of Population Data Science also describes that, so you might find it interesting.
Great. Thank you so much, and thank you all for the wonderful presentation. Patty, Mary, Kathleen, Cynthia, Moyana, I really appreciate your time and all the effort that went into making this presentation possible. Thanks again, everyone, and I hope to speak with you again soon.
Thank you, Anne. Thank you for the opportunity.
Thank you.